Welcome back. We are continuing on
Yeah,
to house healthcare reimbursement rate recommendations that we've received from various organizations, providers. You want to keep going, Daisy?
Yeah.
Doing great.
And so we are in that about middle of the spreadsheet, which is in our budget folder on our House Healthcare webpage. I'm at the Visiting Nurses Association recommendation for a 3.5% increase, which would add 28,000 to the base, bringing them up to 70% of Medicare.
Can I?
On any of these rate ones, Nolan?
So I just want to qualify that I have not verified any of these rates or any of these numbers. These are what the advocates tell us the numbers are. Which may be correct, I don't know, but we haven't verified what they are correct.
Can I ask the VNAs in the room, why is it only in base? Oh, or not base, why is it only in general fund or is
No,
there a match?
It's
Is this-
probably matched.
That 328 is the gross.
I think it just wasn't filled in on the sheet.
Okay,
And I'm happy to sit down with you anytime. We've worked up a rate model, there's a ton of Corrigan and Diva.
I appreciate that. I just need to hear from the administration, like what that, what that number would be. So, I mean, I always appreciate your input. I just need them to verify.
but can I assume, Nolan, that if it's a net increase, a gross increase of 328, that this is all matchable
I would assume that
funds,
this
so
is,
it's like
I would
120
assume
to,
this is matchable.
okay. Okay. Sorry.
Same with the next one.
Okay, so the next one, Vermont Care Partners, 3.5% increase. This is our designated agencies, mental health. This include the SSAs also, Amy. 5.8 million. Any questions about that?
And again, we can assume that that's not all general fund, that might be a lot of federal.
And
That's the
then,
question, how much is federal? Yeah.
No,
we don't know.
it's a, we aren't always clean.
Yes.
Especially this one, it's not always a perfect and straight match. Some of them might be through general fund. So I can't tell you what the number is, on the fact that they will be matching right on the one of what percentage.
Lori, do you want to talk about this one? Because I still always struggle to understand this one.
Which one are you on?
The Medical Society, the professional.
I can do this one.
Oh,
I can. You're so much better at this.
So they're asking for an increase in the professional fee schedule, which is basically everything paid to physician assistants, the fee for service fee schedule. So they're asking for this increase because of the Medicare economic index, that Medicare's rates kind of get adjusted for, they're asking for a match of that. Because that didn't, and she's like, oh, don't screw it up, Melissa. Oh, I'm sorry.
I told Jill I was on this last night too.
And essentially, so Diva this year did not raise any rates whatsoever. They kept the
For
same
Medicaid.
conversion factor for Medicaid.
Medicaid.
And so even though there was a slight increase from Medicare, there was no increase from Medicaid, which means that, I mean, I give the example of like our enhanced primary care rates, we're paying at 114% of Medicare's allowed amount. And this year, because of not having this increase, they're now at 110%. So there's no inflationary increase on the Medicaid rates. Did I get that kind of right?
So could you say those percents again? So from 140 to 110?
14. That was just on the enhanced primary care, I believe. That was the example I think Jessica gave.
So I'm sorry. Say that again?
114
114 to 1.
to now 110.
That's the increase.
Because obviously if one went up, but the other stayed the same, the percentage of it would be a decreased percentage. Yeah. And I will say that over the years, we have intended that the Medicaid rates keep in line with Medicare's rates. So when we don't raise Medicaid, but Medicare does go up. And the Medicare Economic Index, by the way, is basically the rate of inflation in medical costs. That's federal. And we've tried to keep them in line so that they don't fall back down to where they were. All right.
If I may.
Work.
So it looks like there's $2 million for psych, and I'm just wondering how that, what's the thinking behind that? Do we know?
Where are you?
In the.
Oh,
yeah.
That's.
So so it's
Just
just,
a lot, I mean, compared to others.
well, so I'm assuming it's a breakdown by specialty type. So there's primary care and then they break out sort of specialty care, which I think is around, where is it, like 70-80% now? It's less than what Medicare pays. And they're just giving examples here that if this increase went into effect, it would have this sort of effect upon these certain types of provider types.
Which means that psych is really bad.
Psych is really, really expensive and hard to get people here for, so we need to pay premium salaries to get folks to come.
So is that sort of part of what it is attracting a workforce? Is that what we're thinking? It's reimbursements, right? So.
I was gonna say something, but I don't want to say it because I could be inaccurate.
But isn't it just the percentage of on top of, like the percentage on top of the rate that's already been established?
Yes.
So if you do that rate across all of these types, that's just what what that dollar amount
Which means that
is.
psych is so low that it's such a big number. Is that
Well, I don't know.
fair?
Would I be accurate in saying that psych is reimbursed by Medicare and Medicaid actually at a higher amount than even commercial? Not saying it's high. I don't want to put it out there that it's high, but that typically this is the one area where commercial rates end up being lower than Medicare and Medicaid.
You probably know more about that than I do. But
That's I.
Joseph Upgarrett for the Vermont Medical Society, we did put that chart on the back of our budget asks, and it's a little confusing, but we were trying to show how that MEI would bump up the different rates, and it's a little confusing the way that it. So you can refer to that.
I remember the chart. Thank you for my handout. Sorry, did I make that as clear as mud for you, Leslie? Silver loading.
Yeah, it's somewhere in this mess, like.
I think they were just giving us an idea of how it would impact different specialty types.
So can we go to the next one, which,
Can I?
Yeah.
Can I go back to the Vermont Partnership? Two clarifications. One is that request from our care partners is actually their estimates of general fund. So, and not growth. So they're actually asking for, that's the general, that's their estimates of general fund. The second piece I would flag is that it's also across all budgets across DEVA, DMH, and so like last year, you guys did a joint request in the Human Services Committee on this, so that's another avenue you can do as well. But just know this is a request across all AHS and not just. So it does kind of blend.
got it. So if we voted for that, it would be support, it would have to be support, not have to be, but
Doesn't
it
have
would
to
be supporting the services they do for Dale as well.
Yeah. Which we don't often hear about in this committee.
Which one is this?
We're talking about Vermont Care Partners and their requested increase.
Yeah. Oh, okay.
And the last thing I'll add to that too is often, like last year when we did rate increases, it wasn't just DAs and SSAs, we did it across the board for service and other stuff. So the number, it could be different if you are just specific to DAs and SSAs versus including the other folks that sort of get ratings too. So you have to think about that as well. The cost could be more unless you're just specific to DAs and SSAs only.
This number in this request is
That's
specific
just
to DAs and SSAs.
Yes, correct, but last year
Right.
when we did the rate increases, it felt that you can't focus on them, there's other home and community services outside DAs and SSAs, so you did a rate increase for other services, we're very targeted.
And those folks are, like the VNAs in the line above, requested the same exact percent increase.
Yeah, so there's,
Um,
so you could combine them.
actually, I just want to clarify, Eric, with the VNAs. So this increase, is this just targeted to home health, like medical, like nursing home health? Or is it, because this is what happened last year, is that the VNAs, but you also do home care services?
So this is just the Medicaid skilled home health, the
Skilled,
license.
thank you.
And physical therapy, occupational therapy, there's a series of codes.
This is you get discharged from the hospital and the nurse comes and helps you for whatever time. Not the person who comes to help with daily living.
The difference being licensed medical.
Yes. Okay, want to make sure everybody understands that.
Okay, the last line on there. One Care Vermont, population health per member per month and comprehensive payment reform payments, 7.7 million. Primary care alternative payments funding gap. UVM Health Network settlement funds through January 27th. And ahead funds begin in 2028, anticipated. Maybe this is gap funding or bridge funding.
Yeah, which we did. UVM did last year through the settlement, yeah. So it will go, there will be no per member per month payments without the 7.7 million for the year ahead,
Do we really have a choice on
for
this
the
one?
half a year ahead. Yes, we do.
We do.
What happens if we don't fund it?
They don't get their,
The primary day is primary care practices.
The ACO ended, so
Primary care practices don't get,
those per member per month.
that was this famous gap that we talked about.
I will say that I believe in the rural health transformation, that they're talking about a lot of things to do through the blueprint. So, and since they can't do rates or services that are paid for, I think that they're targeting this per member per month. Am I right, Jill? Are you sort of nodding your head?
There's, I'm totally not clear and your pieces are, what we know is they can only pay providers 15% of that 195 billion, right? So it really can't be going, and they don't want to, they can't backfill any commitments budget. But I think it's.
But they can come up with new programs. Okay,
Is that all general fund? I'm trying to read in the notes. Okay, yeah. 5.95 general fund for population health and payment reform is 1.75. Okay, anything else on that section of reimbursement rate? Let's move on to the other non-government recommended requests, starting with the free referral clinics. This work or this request is for 462.5 general fund dollars. The gross of 925. This would bring some positions to full-time in order to increase access to people. Also infrastructure, including repairs and dental program equipment, and they're keeping their electronic medical record up to date. The request is a Medicaid administrative funding match, so that has a 50-50 match. And then there's a breakdown in the notes of how that money would be directed within the free and referral clinics. Brian?
If we give them more, can they draw down more from the federal government and serve even more people?
50-50 match.
Would you like to answer that?
We could, yes.
Thank you. I think we should at least give them that amount, if not more. Considering the need.
We're not talking about like taking a position.
Oh, my bad.
Thank you.
And then, any other questions about free and referral clinics? Guys, we'll go to Bridges to Health. Which is a $500,000 general fund to support transition of the organization to the free and referral clinics. So the Bridges to Health has been looking for a home base for years. They have finally found one. And just to refresh everybody, this work would support people who work for small employers that can't offer insurance are often those that get care in these places. So that's what the money would go toward. And it's often, if I remember right, dental services, adults and youth.
Our population whose only access to healthcare essentially is through our emergency rooms.
Yep. Brian?
And this is just the ask here is transitional money. That's what it's saying, one time, a funding to support a transition. So then, once that transition happens, the program can be sustained how?
I know we asked that question in testimony.
Yeah, I can't remember.
Over bridges?
Yeah,
It's going to,
free and referral clinic
yeah,
But then how do they sustain the funding after the transition? I think that's the question.
becomes part of their budget.
That's
I
just
think-
one time.
I,
Or can they bill? Is that what it is? They bill?
yes, can we ask? So, I realize that you're not, but you're kind of representing free and referral clinics. So the Bridges funding, they're asking for transition money to become part of, be housed within free and referral clinics. What is the plan for funding moving forward to sustain that?
So I know they have.
Can you introduce yourself?
Oh, sorry, Dan Farlow, Executive Director of People's Health and Wellness Clinic, Chair of the Vermont Free and Referral Clinic Board. I'm not the person doing the negotiation on this contract, but my understanding is that they have a pretty robust fundraising mechanism already. That they've been talking to Senator Sanders as well about some federal resources. And that, for the VFRC, our budget would be separate from Bridges' budget internally. So they'd be responsible for their fundraising, would not be relying on the core grant we get from VDH.
Can anyone remind me if what happened with Bridges in the BAA?
We voted to fund it.
We did vote. Did
Oh,
it?
you mean on where?
Let me look into it.
landed.
Can we move forward?
this year?
Yeah,
It looked like appropriations was talking about it again on their agenda this week, so I don't know where.
I'll look.
yeah, that's right. I think it was help us get to July.
So the
Anyways,
Topper said that we're not weighing in on stuff now, we're just asking questions. So I think my question is just, it would be good to helpful when, by the time we make a decision, to know a little bit more about this plan to sustain the money, so we don't just throw $500,000 away on a transition and then the program fails anyway. That would be my concern. So like, if we can just get some info about that.
We asked for 167,700 in the BAA, but no
We
one,
did already.
no one will have to find out if we.
we just don't know what happened to it. That's it. Mhm.
Okay, can we talk about benefit assistance?
Yep.
Benefit assisters is to assist, this, if I understood right, would support staff at 211, Hunger Free Vermont, the Language Justice Project, and other nonprofit organizations to support Medicaid enrollment and re-enrollment, as well as SNAP eligibility and enrollment services direct with folks that are already interacting with their services. They would need to get certified by DIVA as a benefit assister, and training for Medicaid enrollment and eligibility. And this would be about $5 million.
Can I ask a question about that? So it's one time. I'm not sure I understand how that works over time.
Yeah, that's a good question, Leslie.
I mean, $5 million is significant. We can use it elsewhere.
It's certainly an easier ask, but if I recall, Amy said they would accept it being in the base, that one time for now, if they need something, I don't know.
No, did you want to go ahead? Yes.
Yeah, they coach that principles, they are comfortable with everyone. The idea is that there will be a sort of influx of need in this fiscal year as the requirements actually change. So,
Well, because of HR1, is that what you're saying?
yes, this is a direct, this whole package is sort of a direct response to HR1.
How is that different than, I guess it's a whole different thing than we're already adding 12 positions. So wouldn't some of those 12 positions sort of take up the slack, or not really?
No, because these folks interface with people at Hunger Free Vermont, blah, blah, blah. And those internal 12 people are going to be doing things internally to DIVA. So that's sort of a different end of the process, is my understanding.
But that it's not going to be required after this year. Everyone's going to be totally perfectly up to speed.
No, I think it's just that they realize that we're tight on a budget.
That
and
they
so
just couldn't add it to the base.
If you.
It's a workaround?
Assume that there'll be another ask.
Yeah, okay.
Exactly.
Well, it'll be
Thank-
more refined based on their 1 year experience.
But also a lot of this was to get people up and trained, and
Right.
so that, you know, maybe that's something, yes.
That's right.
But
I
I
don't,
think Nolan is right and expect to see next year as well.
this did have a big training component to
Yes.
it.
It'll be different next year.
Any other questions on this one for benefit assisters?
Can I just answer the Bridges question? Yes, it is, in the Senate House, BA as well for $167,000 for Bridges. So
That was for them to move, right?
Yes.
So that was like moving costs.
anyway, answered it was in BA.
Okay, the American Heart Association needs 150,000 one time, which would be grants for schools to implement the cardiac emergency response plans, which are required to be in place by this fall. I think we required that.
I was going to say, who required it?
We did.
Did we?
I don't remember that. I'm not denying. What was it, what piece of legislation was it in?
It was part of the miscellaneous, FFT, this is the American Heart Association, it was part of the miscellaneous ed bill, so the supplement, and it was big.
Oh, so it wasn't us, this committee, it was us.
We did hear about it.
We did hear about it.
Yes.
So they don't have a choice. That is something that they need money to do what we ask them to do.
How come it's not coming from the ed fund?
That was going to be my question.
I didn't raise my hand, I'm sorry.
Because
Is House Education looking at this line
We've
item?
asked them, I'm not in their investment, I don't know, but we've asked one time. Not really come from the ed fund, I think schools, a lot of schools have AEDs, a lot of schools have CPR training, but they were grant funding we thought they could use, it seems like it's being used for other stuff. The safety grants. This is mostly using it for security purposes, so this helps from the schools who are most in need, not everybody would be like the need based.
so you have a request in with House Ed as well?
Or to put it in the budget.
Okay.
Go ahead. Brian.
This would be a question like that may not be answered today, but. And this is not, once again, about supporting or not supporting, so I don't want to be taken that way, but. the question is like, once we invest in this, how do we sustain this equipment? Because AEDs don't last forever, and there should be some plan in place to make sure schools are maintaining this equipment so that if there is a cardiac emergency, we can be guaranteed that the stuff is there, because it would be sad if that stuff failed when it was needed after we spent money on it now. So I don't know, will it be maintained by like school budgets in the future, or is the state gonna have to plan for this? That would just be a question here.
May I ask Tina, how much are the grants through Bisbit?
And safety grants that are up to $10,000 that schools can use for safety issues. And so they told us that they can be used for AEDs, and no one's been denied to use them for AEDs, but they're using them also for things like security cameras, signage, go kits. So if a school has those needs, and they would, and in which case it's either absorbed in the school budget or there's budget.
Any other questions on this? Right? New section.
Awesome.
Oh, I'm sorry, go ahead now.
No, I don't. I'm sorry if I'm, back up, I'm sorry, to Vermont Free Referral Clinic. So it looks like, well, I'll ask, how much of that goes directly to the people who are seeking help? I mean, this looks like it's staff
So
and infrastructure.
I see the free and referral clinics, first of all, there's no cost for people seeking
Right.
care.
Or-
And also, I do know that their providers are all voluntary. So the actual provider is providing it. This money is for staffing, like the person, the receptionist that checks you in. I know that I'm not sure if it was within committee, but I do remember I had a conversation with Dan Barlow, who just left the room, that his clinic in Barry, he actually, their need has been so great that he's trying to expand the hours of it. So he needs like the staff personnel to be able to expand the hours. I think they're only open, how many days that they're open now?
I didn't know they weren't open all 5 days.
I think this is to expand actually to 7 days. Because their need has been,
Right, so I love what they do. I'm just wondering how much of that money is for like the actual medicines and all of that that people need.
well,
Doesn't seem to,
587 for increased staffing. So those are the people that just staff the clinic for sort of administrative purposes. 60,000 for IT, I think EMR for their electronic medical record. Increased costs on that. And then 278 for infrastructure. I'm assuming that's for things like fixing the hole in a
It
roof.
says specifically things like equipment, dental equipment, things like that.
so where does the funding come from that they use to buy like all the medical necessities that help these people?
I think it comes from all of this sort of stuff.
There's a base amount already in the budget that we.
This is just an increase. They do have a base amount.
And then also, people donate. They have fundraisers and people donate to the free clinics. The person who goes in there doesn't pay anything.
I would add though that this is a recommendation the committee adds, that you include language being very clear about what the money is used for. So that when a department goes to issue a grant, it's clear what the intent of that money is. Otherwise, they may do grants that aren't specific for the intent.
And just to let you, I'm looking under our testimony for budget and there is there is something from, if you look under Dan Barlow, there's written testimony in there that sort of tells you where everything's going. Okay. Any other questions on that? Can we flip the page? Let's flip the page. Home stretch.
Don't get too excited.
Okay.
This,
All right, does either Daisy or Lori want to speak to this? Because we didn't actually hear anything directly on Dulce, but people on the committee will remember probably that program. Does anyone want to, either one of you want to speak to it?
What I remember about this is it's not funded, again, in the governor's budget. But it works across 6 different sites and that funding's ending. So it just simply was not funded this year, but it's been in the VEH budget for as long as I can remember. Works with mothers and children.
Okay, so we need to have an understanding of Dulce.
What?
What is it?
He doesn't know what Dulce is.
I recall, gosh, you guys are, oh yeah, let's ask somebody else.
Jill set up here, and so it's a team approach to providing care for newborn and their families. And so, it typically has a pediatrician, there'll be, early childhood development, there'll be other services that are connected. And, so you're getting this wraparound services, and it's just had really great outcomes for families that are at risk and
Is this the full program or was this an expansion?
Last year, I think it was, funded at 600,000 and I don't think this is an expansion. I just think that this is the cost for the current.
So if we don't fund this, it goes away.
Right, so I can, double check on why it went from 600 to $1 million. I think it's just the cost. Yeah, this is the.
If you could double check that, because I also remember us having a big debate about this and there potentially being an expansion. Or as part of blueprint, is that all right?
It was the
It's
blueprint
it was in
integration.
the blueprint. I mean, I remember, I can still remember Dr. Levine sitting in front of us,
Talking about this.
talking about it. And it was,
This is the only funding for it now. I can get you more information.
Next, we have a request from United Way. This would help to integrate their Epic EMS and 211 so that those data systems can talk to each other, allow clinicians to be more seamlessly communicating, and theoretically patients to be treated more with a more comprehensive view of their whole health. The request is 332,000. I didn't have a general fund amount for that. I don't know if Nolan.
I think you would assume it's a general fund grant.
now, didn't DMH have in their budget a cut to 211?
Yeah,
So this is essentially replacing the cut that was made.
this is for something different. That was for services that would reduce the hours of availability of 211.
oh,
Getting rid of the overnight.
Yeah. Oh,
This is
okay.
Specific to the connection with Epic to be able to refer people seamlessly.
Where was that on our, where is that on our spreadsheet? I see like a notes on it.
But we didn't-
It's not actually aligned.
I did, for the removal, we did not include it.
Okay,
For the down of the cutting of this, of the overnight. We
okay.
did not include it. We can include it. And I put the line in the wrong spot. So where it says Epic and 211 integration under the community outreach, that actually should be on the 211 line,
Okay,
which is,
Okay.
I'm fixing on the spreadsheet.
Okay, any questions about that Epic 211 integration? Help with referrals?
Can I ask our JFO or even our legislative council? We have a health information technology fund. Does this seem like the type of thing that perhaps would qualify for for an appropriate use of our HIT fund?
I would think it does. And if it doesn't meet specific languages, you can always not withstand, but I think probably does fall into an appropriate box. Like, I don't have the HIT fund language in front of me, and probably,
Say, I can see generally type.
But in terms of on the surface, it seems like an appropriate use. And there is money in the fund covered.
Thanks.
As long as it would go to. Okay, last and definitely not least in this section is for the Office of the Healthcare Advocate. For staffing and services, they're looking for 450,000. That's listed in here as general fund. However, it's not really all general fund. There's a breakout of it that Mike can get to us. So it wouldn't actually be a full 450. Right.
And you might have just said this, but like, is this an increase or is this the yearly amount that we invest in the office?
This is an increase in their base.
An increase in their base. Can you maybe remind us what your
you.
base has been and how it maybe has changed over the years?
And what percentage this is addition?
Base has been for a couple of years, $2,406,000.
It's like a 25% increase.
So 3 years, I think. And just to, sorry, Mike Fisher, healthcare advocate. I don't know how much of this could be general fund, but of our base, a section that comes through the agreement on here was build out provision, 27.5% of that is general fund, and the rest is back to the industry. A section of our money comes from DFR. I actually don't know. I think DFR is generally a build back machine that generates money for its purposes, and a section of our funding comes from DEVA. And there's a small Medicaid matched portion of that. I think my memory serves me right, 275,000. And so what I'm trying to say is we come from all kinds of different places to fund our office because we serve people throughout all over the state government. So I don't know what opportunity for the additional piece of where it could come from. That's the thing.
I think Brian has another question.
So just that, what I was hearing is that there's a variety of mechanisms that generate the revenue needed to fund the office, and that those mechanisms and that revenue do trigger some Medicaid money as well. And so this $450,000, will this trigger Medicaid money?
Don't.
Okay, it's okay if you don't, I'm just curious.
I think it depends on what they're using the money for. So that I think we would need a cost allocation, like we're gonna hire this many people who do this, we're gonna use, and that's how you determine what can be billed where.
Thanks. I mean, the reason I ask ultimately is just understanding what investments are going to yield. And sometimes when we invest in something and it draws down money, that money is yielding more than what it says on paper. And I think it's important that we understand that. So even if you don't know it perfectly, it's good to know at least this appropriation could trigger some investment from the federal government.
Can you remind us what the intended uses are?
This is, I think, remember, I had the picture of our staff. We're running our office. This is the cost of doing business, the increased cost of doing business, including health insurance and various other inflation to run our office. And I'll also mention, last year we asked for and you gave us some increased responsibilities. We are doing our best to show up everywhere to builder's responsibility.
We did write you into a whole bunch of things.
So it's, this gonna be additional staff to do certain things?
No, this is steady state.
Oh, yeah,
So then we'd have to figure out the percentages, just like a percentage increase. So we have to figure out the breakdown. And then,
And I'm working with joint fiscal and appropriations committee, I can't remember his name,
James,
to try and get a breakdown.
yeah, James is calling me, so.
Mike, the tasks that we had for your team that were in, 226, 68, X 68. Were those,
Yeah.
and also, did those have money attached to them?
Yeah.
Okay. They gave you more authority, but they didn't task you with anything specific, did they?
No, I mean, in fairness, it gave us, it expanded our required, where we are required to show up to advocate on behalf of the Congress, in line with what we were, trying to achieve anyway. I think this previously recognized our role with DEVA particularly, and we advocated with DFR or with, every part of state government. But no, there was no money attached to those.
And you said it's been 3 years since we've gotten that.
No further questions, Your Honor.
You didn't read your increase last year? Or in the DAA, I thought you did a 320. No, am I imagining that? Because there were like 2 years that you didn't, remember, because I said you should have asked for more.
Last year.
Yes.
Last year, you said I should have asked for.
Tell them that.
I didn't ask for anything.
Yeah, that's what I'm thinking of. I thought
You were right too.
you were right.
Okay,
We're on to the language only part.
The language only is,
Well, doesn't this language have a fiscal impact?
am I? Oh, I'm so sorry, I missed that, never mind. It's my bad.
so I think everybody now at this reviews this considers their top 5 priorities and remembers we're gonna add a line for staff. And there is a down for 211 on the DMH section, so maybe should we put those in and then reprint it for people?
Yeah.
How much does it cost of the paper?
Thing with Sash.
I don't have to discuss it, you.
I don't know.
You don't want one?
And then
Can we go just write the change on this and save the paper?
That's fine.
can I just say, for those of you who haven't done this before, it's really hard.
Yeah.
And
For those of us
yeah.
who have done it before,
So
it's really hard,
hard.
really, really hard.
And we have a very, very, very tight budget.
So, let's get new spreadsheets. So this is how I'd like this to work. So we will go through and I will ask each person
So we're
to
gonna,
prioritize personally their top 5. Gonna do 3. Gonna do 5. And then what we do, and well, actually, technically, particularly in the governor's recommend, I don't think, unless you have something firmly that you are adamant should not be cut, or should not be there, we're gonna kind of ignore the rest, that nobody rises to any level whatsoever of concern.
Let's say that again.
So, I mean, typically we've always kind of done it where, we'll rank the governor's recommend and then we'll rank all the other things.
you're saying without objection, we're gonna just let those move forward?
Yes,
Okay,
yes.
But we can object.
We can
Yes.
object, but your objection needs to be in your ranking of 5.
Okay, what if we object or don't object, but we don't agree with the figure?
Well,
Like the
I don't,
prescription copays, for example,
Pardon?
like prescription copays, for
Yeah.
example.
Something like that, yeah.
like, I think the prescription copays, personally, I think that that's something that we all should talk about as a committee. And, either, and then maybe come up with a recommendation of where we'd like it to be. And if we have consensus around that, then we would say, yes, this, but we recommend that. I think for things like that, that we're changing those numbers.
So what about like, and you all know this, I'm an advocate of the Visiting Nurses Association, important up my way. But it's a 3.5%. And what if I say, well, I'm looking out for some other things too, maybe 2.5%.
Okay, so this is where I'm giving the great question, because it allows me to say, I really don't want people to concentrate on the numbers that are on this sheet. Because remember, we're a policy committee. I want us to make our best recommendations to House appropriations on the policies and the areas that we are clearly ranking as. So what I would do, Alan, is if I were you, just based on what
That's
you
fine.
said,
Yep.
I would give B&A as my number one priority, because I guarantee you, this is going to get to House
Okay.
appropriations, and they're going to look at it and say, hey, it was a really, really big recommendation, but now we got to find the money, and they're going to figure out the money piece.
Yep.
So I don't think it's up to us to figure
Fair
it
enough,
out.
that's fair.
The
No,
copay thing's a little different because the actual dollar amounts are in the policy.
okay, no, that's fair.
I'm gonna go Tupper and then Brian.
So, just so that I'm clear, this top piece here,
Yes.
we're not gonna do anything with that,
Well, no,
unless we want language. That we might disagree with something.
unless you cared very, very deeply that nothing in here gets cut,
Or we add that.
or that we add that. So like if I wanted to do, the third priority is education loan repayment. It's just the first thing I saw on the list, so don't anyone get all excited. So I can see from here, then that would be one of your priorities. Like, I do not want that.
So we prioritize them,
We
but we
prioritize them.
don't change
So,
any of the proposed description.
The,
so where does that come out?
Same as we usually do.
I'm not explaining it very well. And that's language, that's just language we're putting in. We'll talk about language we're gonna put in. That doesn't change anything.
Okay, so then,
The way to explain it is, don't look at the divisions,
Right.
right? We used to look at the division. We are just gonna rank your top 5 on this entire list.
Oh. including the
Entire
governors.
list.
The entire list.
I thought you just said we weren't gonna rank those.
yeah, but
You said that we were gonna let them move forward without objection.
No, I don't want you to rank like, again,
Yeah,
I'm throwing out whatever I can happen to see. Unused drug repository. If you want this, I don't want you to rank that as your top priority because you agree with it.
so this is, so we don't put 1, 2, 3, 4 in the top ones.
Yeah.
We just flag it if we object.
No, if you object and if it's a real priority for you to object.
Oh,
That's
so
what we
if we
want.
object, then we should rank it once we object.
Yes,
Okay,
that's what thank you. That's what I'm doing.
okay, so can I ask my question now, because I was up to Popper? So now I understand it differently. So if we support the recommendations or requests below the governor's recommendations, we would express our support by voting yes and ranking it
Mhm.
in order of priority.
Yes.
And if we oppose one of the governor's recommendations, we would include it in those rankings as a vote of opposition.
Yeah.
But that you are not asking us to vote in support of the governor's recommendations as a priority,
Yes.
because they're gonna pass otherwise.
Yeah.
That is helpful, so we don't waste a vote on something that's gonna pass anyway. And you want us to rank 1 to 5,
1 to 5.
and you want us to indicate that in the priority position on our new spreadsheet?
Yep.
Okay, that's all I need to know. I can complete my ballot.
So we will go around,
Right?
we will go around tomorrow. Everyone will rank their 1 to 5. We'll tally up all the votes that all the things got. Nolan hopefully will do the math. I always say, like, if it's your top priority, number 1 priority, Alan, VNAs, and he ranks at number 1, that's going to be 5 points.
It's ranked choice voting.
It's, yes, so every vote gets a rank, and then we add up the ranks of everybody's, and those are the recommendations that we give to House Appropriations. We will send them this whole spreadsheet, by the way, but we will have on it where the committee landed. And then we'll do a straw poll on whether or not we
So
agree with sending our choices to
The final results.
our final results.
We'll ratify
you
our
just went
election.
through that with Brian. Now I have a different,
Okay, Leslie has a
Well-
question though first.
well, I'm sorry.
Oh, no, I mean, mine's clarification, mine's easy for Amy, if I may. It says here that it brings up to 70% of Medicare for skilled nursing.
That's not fair.
That's not you, sorry. That's you, sorry. Can you tell me what it is now?
It's a little under like 78%, Eric Covey for the record, Venus, Vermont. And that is, brings up most skilled home health Medicaid rates to at least 70%.
And I didn't hear what you said. What is it now?
Like 68%.
68%.
It depends on the billing code. It's different for each billing code.
Yeah,
So
But average.
a nurse or physical therapist or whatever the code that's being billed,
so it's really only bringing it up 2%? Is that what I'm understanding?
that's correct.
Okay.
And
3.5% on there is actually correct.
It says 3.5.
3.5% is the dollar.
That's the dollar amount, but it's the actual,
But in comparison, if that is the percent increase to a dollar, for the dollar amount for the rate.
It gets you 70%.
It's not a clean 70% because I just went with a flat 3.5%. And again, some of this is imputed because Medicare pays on an episodic basis, whereas Medicaid pays on a per visit basis. So there was methodology with Diva, we had to work out how to do the comparison.
Do you have a spreadsheet you can just send me?
Yes, yes.
Okay, and we'll look at the detail here.
Yep, the one thing just about the 70%, because there's a policy component rather than just a numbers component, that doesn't account for bringing rates to at least a benchmark of 70% for those rates like pediatric palliative care and high-tech nursing I discussed that are really out of balance right now. Those are maybe at like 30% or so of their corresponding Medicare rates. And that would be a bigger fix to change those. So the 3.5% just accounts for 3.5% of those rates. But those wouldn't get to the 70%.
but it's
That was
across every
just-
rate.
It's easier
This-
to do a
the
raise.
70% was-
Or than it is to do specific pieces.
And that was just a narrative. So you know that the 3.5% gets most rates to approximate, like at least that benchmark of 70% of Medicare. Now, if there was a policy decision of we're gonna bring home health rates to 70 or 75% of Medicare, it would be a different calculation. But with Diva, we're prepared to do that too.
So could you remind me of your name so I can find your testimony?
Yes, it's Eric Covey.
Oh, yeah, thank you.
Yeah, thank you.
I'm just gonna give an example. If I thought that, the, used drug repository, if I felt strongly
Yeah.
that I felt strongly that that should not be cut.
Yes.
I don't rank that as my,
Yep.
So you do.
You do. Like, that's one of your 5.
Not cutting is one.
Not cutting is.
Blocking a cut counts as a priority because it's an investment if it's not a cut. See, I get her logic.
I get that, I get that.
Okay.
I'm just trying to, you know, when you got your explanation, it was different than the.
It did change, yeah, it did change, yeah.
I'm gonna go back to what Laurie said. We are in a very, very, very tough budget year.
Yeah.
And I'm not going to send something to House Appropriations that just says, we love everything, because we do love everything. I mean, every single
Almost.
thing on this list, almost everything on this list is important. And we're here to make these hard decisions.
I know there's some hard decisions.
Yeah.
Do we know maybe or how it could affect the rural healthcare transformation affects what we do and say here?
I don't believe anything other than what the administration, AHS has given to us as reasons of, we think that rural health transformation will be a new program within this. This does not affect any of that money that will be spent.
Be hard to believe 193 million will be seen.
It
Okay,
will be seen. We've had several presentations around rural health transformation. It's important for people to remember that money cannot be used to just backfill something that's already there. That's not what it's for. For transformation, which we still don't have a definition of.
But which can mean anything, yes.
Any other questions? So we'll do this tomorrow.
Thank
If
you.
anybody has questions in the meantime and needs help with their, like translating their priorities into recommendations, let me know, call me, text me.
You know what I would recommend or request, even though I don't feel like I need this, it might be good for us, is when it's time to vote, if one of our leaders, like you, whoever's leading the process, restates the process to us one last time after this discussion, so it's really clear, you know what I mean? Because I think I get it, but I still think it'd be nice for us as a group to start off with okay, everyone, here's your ballot, here's the column, here's how it works. Done.
Well, you should, I'm gonna suggest that when you come here to vote, you have your rankings already done. Don't sit and do them in committee. That's
But we
not
may
the
not know
time
how
to
to
make those
complete the ballot
decisions.
accurately, so I'm just saying, explaining to us how to fill out the thing when it's distributed would be useful. Even though I think I know what I'm doing, I think it might help us to just have someone be like, ready, everyone?
Can I also just say Sash is not on this.
Yeah.
So I want to be clear that yes, have an idea, but we're missing one important one.
We're gonna print them another one though.
Is there a
Okay.
dollar amount?
Can I ask a question? Nolan, are you gonna get any additional numbers on some of these outstanding matches? And if you're not, then we can print, but if you are, we should wait.
I don't think I'll have answers for tomorrow.
Okay.
There are certain small corrections that I would recommend making.
Okay, so then Daisy, I updated everything, so.
We're not doing this until 1:00 tomorrow. So,
We can think about it in the morning.
so we won't print anything until 12:00. And so you get a fresh copy at noon. Okay? Just in case new numbers come in. And I do want to say that I think that one thing that I would like to have a discussion tomorrow around this increasing copay. And, maybe we can have a policy discussion with the committee about that. All right. So I think we're done for the day.
Is Sash gonna be on?
Sash will be on the
This
new
list.
list. It'll be on the new list. Okay. We can go off of live. Thank you, everybody.